Thank you. Thank you, Dr. Shabu, for inviting me in such a clinical medicine update by Mayo Clinic, and chairperson for your nice introductions. And during the independence, 1947, average life expectancy was around 34 years, and two-thirds of the death was due to communicable disease, one-third was due to the non-communicable disease. Scenario reversed in the 21st century. Now the life expectancy around 67 years, and two-thirds of death due to the non-communicable disease, whereas one-third of death due to the communicable disease. That is why when you go across the different CME conference seminar across India, we see 90% topics on the non-communicable disease, maybe diabetes, hypertension, thyroid, and so hardly in one or two topics on the communicable disease. But in last 5,000 years, history of mankind has intertwined with the history of infectious disease. The infectious disease has governed the pathway of human history. Even the great warrior emperor was helpless when they faced the pandemic epidemic of different communicable diseases. Fall of Roman emperor was due to the plague, that is called Justinian plague. Even the Alexander the Great, when came to India, when returning back to Greece on the way in Babylon, he suffered from some of the tropical disease. Some say it may be cerebral malaria, some say it may be scalp typhus, whatever may be. He died due to fever, due to some infectious diseases. 19th century India faced so many epidemics: plague, cholera, smallpox, so and so. Treatment facility, only 10% of Indian were under cover of actual allopathic medicines, and populations was basically dependent on Ma Shitola for smallpox, Olai Chondi for cholera. In the Jima editorial 1947 August, the editor mentioned that during the independence, almost 50% death was for the children under 10 years. And the statistics that he presented was only the tip of the iceberg, because that time surveillance of the disease was very pure. Anyhow, after the independence, scenario change. Government of India had taken so many measures on public health program, particularly the vaccination, clean water, vector control, and so on. So that is why in 21st century we see the death due to the communicable disease has decreased dramatically, at least at the beginning. But in this century again we have seen so many resurgence of tropical diseases, and particularly the last pandemic, the COVID pandemic, had opened our eyes. We understood that we should give a relook to the policy, whether the policy for the individual management or as a whole health policy, we must give a relook. From that background, we like to understand what should be the appropriate way of managing a tropical fever from a tropical physician. What is tropical fever? It is the infection that is more prevalent in the tropical countries. So basically there is some difference between a tropical country and a temperate country. The tropics are basically hot, humid, there is excessive rainfall, there is a biodiversity, population explosion, poor healthcare facility, pollution, poverty, so much so. This is a very good area for the growth of the organism and growth of the vectors. So that is why some of the infection we get in the tropical areas, that is not common in the temperate areas. So there is some infection that is only confined to the tropical area, like dengue, malaria, kala-jar, chikungunya, so and so. Some infection are present both tropical country and temperate country, but more in the tropical country, like tuberculosis, HIV, influenza, all together come on the domain of the tropical infection. The domain of the tropical infection, basically we can divide in the three categories. One is the vector-borne, food-borne, water-borne, and that is very important from the public health viewpoint. And there are so many examples what the mosquito, ticks, sandflies, mite, rodents, along with different food, particularly the water. Water is a very important vector of communication of the different organism from one person to another person. So common infection, if you come in brief, what are the common infection, what the tropical physicians face? They are the dengue, malaria, scalp typhus, enteric fever, leptospira, chikungunya, leishmaniasis, Japanese bee encephalitis. This covers, along with some viral infection, covers almost 90% of the tropical infection. So we need a holistic approach, because in our country there is a healthcare facility, at least more than 50% case areas is not widely available. Also people are poor, people cannot afford the appropriate investigation or medical facility. So we have to adopt some policy so that we can identify the disease or the etiology of the disease very quickly. And even if we cannot identify the organism, we can very appropriately start the empirical therapy that can cover, without investigation, at least 70 to 80% of the organism, and people get benefited out of your empirical choice of therapy. So when the first patient come to you, it is called the acute febrile illness. So patient have 3 to 7 days of fever. Patient may or may not have some localizing signs, all under the category of acute febrile illness. Then is coming to the acute undifferentiated fever. When the patient will come on the second day of fever with some cough, that means patient have some localizing sign. Some of the patient have no localizing sign, no features of cough, sputum, no features of diarrhea, no features of burning sensation, urination. So that is called the acute undifferentiated fever. So all fever patients are acute febrile illness. Those fever has a localizing sign, one category. Those fever has no localizing sign, another category, that is called acute undifferentiated fever. So clinical challenge mostly from the acute undifferentiated fever. And tropical infection very challenging to physician, because there is a lot of asymptomatic and subclinical infection that does not come under the cover of the treatment, and that is create as a good vector for the spreading of organism from one person to one person. And also there is a mixed infection. Often we get the dengue and malaria in the same patient, and overlapping symptoms, because many of the classical symptoms we know, the malaria, alternative fever with chill and rigor, but that periodicity nowadays we are lacking. We are getting the different picture even from the malaria. Changing clinical profile. Vivax malaria is known to be benign malaria, but we are getting now complicated Vivax malaria, like that behaving like a falciparum malaria. So these are the challenge of a tropical physician that we encounter when we are facing a patient with a fever in the tropical country. So all these issues have to keep in mind when we are particularly dealing a case of acute undifferentiated fever, that means has no localizing signs. So three very important, one is the proper history taking, proper examination, and relevant and minimum investigation, because tropical patient cannot afford a battery of investigation. You cannot send the fever profile for the all patients. So minimum investigation, you will reach to the more accurately reach to the diagnosis. That should be the protocol. So how we can obtain that protocol? At the beginning I told proper history taking on different aspects, and also the investigation, clinical investigation, if possible every day, is very important. On that basis of history and examination, we have to categorize the patient in a syndromic approach, because when the patient will first day will come to you, it is a acute undifferentiated fever. You cannot localize any symptom. All patients have fever with body ache, with running nose, body ache, maybe some poor appetite, and this and so on. So no rash, no jaundice, no hepatosplenomegaly, no convulsion, no neurological symptoms. So acute undifferentiated fever. As the days passes, patient will develop signs and symptoms. So every day, if possible, examine the patient and try to find out some of the clinical signs and syndrome, and on that basis, signs and symptom, you can categorize the patient, and that is called the syndromic approach of a tropical fever. So what are the syndromic approach? Patient can come to with acute encephalitis syndrome, patient can come with fever with rash, fever with hepatosplenomegaly, fever with lymphadenopathy, fever with AKI, fever with jaundice, fever with hepatorenal syndrome, fever with arthalgia, fever with ARDS, fever with multi-organ failure. Why this is important? Because every syndrome has its own differential diagnosis. So if you can get some of the signs of syndrome, fever with hepatosplenomegaly, you have a small differential diagnosis. even if you do not have the investigation. So you can treat more accurately, you can give the more appropriately the empirical therapy. That is the challenge, or that is the issue or of clinical examination and history taking in a tropical fever, and we can accurately place the patient as a syndromic approach. So I am coming to a model case. What is the case? 50 years male in India, developed fever with moderate chill and rigor, body ache, headache, nausea, vomiting, abdominal discomfort. And you see there is no other patient came to you only the second day of fever, no other signs and symptoms. So that means you are dealing a case of acute undifferentiated fever, as there is no localizing features. So you have taken all the history, particularly the geographic location, any prodrome, history of recent outbreak in their locality, history of illness to relation to the incubation period. This is very important. Travel history, occupation history, important past history, family history, all the history you have taken. And among the history I have red marked the incubation period. What is the probable incubation period? That can give you some of the clue of the etiology. Suppose patient was in Mumbai, was a migrant labor. He has come back to his home village and developed fever after 10 days. So leptospira has usually 10 days incubation period. So duration of possible incubation period can give you idea of the etiology of this fever. So in the tropical fever, probable incubation period is very important. Next is the probable exposure to the contact. If the patient is an agriculture worker, he go to the paddy field regularly, there is a chance of the bite from a mite. So that means if that type of patient develop the fever, there is a possibility of the scarf typhus. So possible, or patient has go to a temple, has taken some charanamrito. So there is a chance of ingesting the contaminated water. So chance of hepatitis or enteric fever chance is more. So possible exposure with the contact or the vector, you have to take the history and you have tried to understand. Next important fever is the pattern of the fever. What is the pattern of the fever? All details cannot be discussed in next 10 to 15 minutes. So just I will give some highlight. Suppose if the patient have step ladder type of pattern, chances more in case of enteric fever. If patient has a biphasic pattern, that means 2 fever peak in a particular day, chance of dengue and leptospira is more. So this patient, on the first day when came to your emergency, you have done the malaria rapid kit test, because by 15 minutes you will get the result, malaria excluded, and you send the blood for the ELISA for dengue NS1. So by the evening you will get the result. So first day you can exclude at least 2 diseases, one is malaria and another is dengue. So differential diagnosis on the second day as a acute undifferentiated fever in your hand, there is a dengue, malaria, different viral infections, scarf typhus, leptospira. Dengue and malaria you can exclude on the first day. So your approach is febrile illness without localizing fever, malaria excluded, you send the dengue NS1, you send back the patient at home with the advice that you observe the red flag signs. If you observe the red flag sign, immediately you call your physician or come to his emergency. Then you will be hospitalized. Otherwise, up to 72 hours, you need no antibiotic, only take paracetamol water and inform your physicians about your clinical signs and symptoms that may develop. What are the red flag signs? If the patient start massive vomiting, urine start becoming the yellow, patient become confused, patient develop lot of rash, these are the red flag signs. In that case, immediately you rush to the physician or observe up to the 72 hours without any antibiotic, and observed after 72 hours, again you come to the physician. On the 4th day when patient came to you, patient developed the conjunctival hemorrhage, maculopapular rash over the body. So this is the 4th day. That means now you are dealing a patient with fever and rash. So now you have put the patient in a syndromic way. I told fever with rash, one syndromic approach. So in the rash patient develop, now you observe what is the distribution of the rash, appearance of the rash according to the day of the onset, and characteristics of the rash. So these are the distribution of rash. According to the distribution of rash, you can identify what can be the probable organism without any confirmatory investigations. So days of appearance, when the fever first developed and then when the rash develop, this duration also, can you give up some of the etiological prediction? Suppose third day fever is the smallpox, nowadays not happens. Fourth day fever is the measles. So this is the way you can identify what can be the probable organism for that of the fever. So I told every day you will observe the patient. Fourth day patient, your approach is fever with rash. 7th day when patient came to you, patient developed jaundice, and you examination you found patient has a hepatosplenomegaly, and 10th day patient developed acute kidney injury. So patient from India developed fever, initially non-localizing features. 4th day developed conjunctival hemorrhage, and 7th day patient developed jaundice, 10th day AKI, and patient have hepatosplenomegaly. That means now you are dealing a patient syndromic. What is the syndromic approach? Patient with AKI, patient with jaundice, patient with hepatosplenomegaly. So what are the DD of patient with hepatosplenomegaly? Short duration fever, malaria, enteric fever, hepatitis, and leptospira. What are the differential diagnosis? Fever with jaundice, hepatitis, dengue, malaria, leptospira, scalp typhus, different chronic bacterial infection. So, but dengue usually patient have asymptomatic elevation of SGBT, not the frank jaundice. Frank jaundice happens with hepatitis A and leptospira. So, left hand side that the different pattern of the if the fever subside with appearance of jaundice, chances more of the hepatitis. But if fever persists even after appearance of jaundice, your chance is either malaria or leptospira or septicemia. In this case, the fever persists even after appearance of the jaundice. So that means chance of viral hepatitis is less, rather than other malaria, leptospira, chances more. So in this way you will analyze from the syndromes and the signs of syndrome what can be the probable organism. And third syndromic approach I told is the fever with renal failure. So what are the disease that can present with fever with renal failure? It is the malaria, dengue, leptospira, bacterial sepsis, salmonellosis. These are the disease that present with fever with renal failure. So differential diagnosis, now again we are again coming back to the differential diagnosis. So what are the differential diagnosis? At present, patient from India develop fever, rash, conjunctival hemorrhage, hepatosplenomegaly, jaundice, and AKI. Malaria and dengue excluded at the emergency, and jaundice is less likely. I told with dengue and enteric fever, here only asymptomatic elevation of SGBT is more. In viral hepatitis, usually jaundice after fever subside after appearance of the jaundice. So viral hepatitis chance also less. So that means we are dealing a case with fever with hepatorenal syndrome, because both patient develop AKI and jaundice. So what is the differential diagnosis? Among the left hand side, among all the differential diagnoses, most likely diagnosis is leptospira, that usually present with fever with jaundice and kidney injury. So we have done the appropriate laboratory investigation, liver function test, complete blood count, malaria and dengue done at the before. All the culture we have sent, serological test we have done. I am coming in very brief. Molecular test, CSF analysis, radiology, chest X-ray, ultrasound, CT, MRI done, and from the other serologies, it is found that IgM leptospira found positive, but others are found negative. That means now you are dealing a case with leptospira. So this is the importance of syndromic approach. Even if you do not have the facility of IgM leptospira, if you analyze the day by day the symptoms and signs that evolve in the patient, and you can analyze as per the differential diagnosis, you can very well give the empirical management of that tropical fever. So if the patient can afford, or your healthcare system have the facility for IgM, that is okay, you can do. But at the same time, without investigation, from the knowledge of the syndromic approach, you can give the empiric treatment that may be appropriate, or that can cover the 80% of the organism, or can be very appropriate for your patient, and that should be the actual guideline for a tropical physician to treat a tropical fever. So again we are coming back to the entire issue that I have discussed. The patient came to you with acute febrile illness on the second day. You got no localizing findings. So that means without localizing finding, now your case is acute undifferentiated fever. Malaria, you excluded emergency within 30 minutes. Dengue NH1 you send at the emergency. By evening you got the report. You ask the patient, up to 72 hours. If you do not have any red flag sign, you remain in the home and inform physician daily up to 72 hours without taking any antibiotic, only taking paracetamol and plenty of fluid. If you find any red flag sign, immediately you consult your physician and be admitted. After 72 hours, your duty as a tropical physician to examine every symptom and to find out is there in any appearance any signs of symptoms like rash, jaundice, renal involvement, neck rigidity, convulsion, hepatosplenomegaly, arthalgia, and accordingly you classify the patient according to the syndrome. Or fever with arthalgia, fever with rash, fever with hepatosplenomegaly, like this, and each syndrome, each category has its own differential diagnosis. So your differential diagnosis will be shortened. So you have put the patient is a syndromic approach of the tropical fever, and you send the relevant investigation that is available in that locality and treat accordingly. If the fever not subsided by 2 to 3 weeks, then you categorize the patient in the PUO. After 72 hours, you can start the empirical antibiotic. What is the best empirical antibiotic in our tropics? It is the doxycycline and or ceftriaxone, because doxycycline can cover host of organisms in the tropical country, particularly the scalp typhus. Difference, even it can decrease the proliferation of the dengue virus also. That is why it can cover the salmonella, it can cover the scalp typhus, it can decrease the viral replication of the dengue. So if the doxycycline is combined with ceftriaxone, it can cover almost 70 to 80% of the host of the organism. So either you do not use the antibiotic. If you use the antibiotic, your first choice should be doxycycline and ceftriaxone and or. So tropical infection management is a both clinical challenge, one diagnostic challenge, one is therapeutic challenge. But most important is the clinical examination and analysis as per the syndrome. I told put here diagnostic challenge was just I want to, is a long discussion. This is also one chapter, but one point I want to highlight. There is a lot of cross reactivity, because we mainly the tropical physician depend on the serology, on the IgM, IgG, antibody based assays, but with the antibody based has a lot of cross reactivity, because in the patient of dengue, if the IgM of dengue may be positive, but at the same time IgM of other infection, other flavivirus, even for the non-flavivirus of IgM for the scalp typhus may be positive. So there is a chance of, if we based on the antibody based assay, there is a chance of false positivity of other infection. So that it can confuse you. During the last dengue epidemic, I from the West Bengal government sent me the Murshidabad to visit. There I have observed 580 cases of dengue, but among them 100 test IgM positive for leptospira. Leptospira was not present, but it was a false positive IgM positivity for the leptospira. Here is the importance of your clinical examination. If you do not found any other signs of symptoms of leptospira, because confirmatory investigation is the PCR based or culture, that is not easily available or we cannot afford. So we have to more and more we have to depend on the clinical history, signs of symptoms. On the top we have to apply our basic sense, our investigation, and empiric therapy is the best therapy in the tropical country. Thank you. I welcome to Epicon Kolkata in 2025. Thank you. Thanks.